I'll be talking on choice of graft in non-union of scaphoid. Scaphoid non-union is scaphoid fracture diagnosed 6 months from the time of injury or the time of treatment. It is a failure of non-operative or operative treatment for acute and subacute scaphoid fractures. We order this set of X-rays, X-ray PA view of the wrist in ulnar deviation, lateral view, oblique view, and elongated view of the scaphoid. X-ray is basically to see the site of non-union, whether it is at the proximal pole, whether there is a waist non-union, or whether there is a distal pole non-union. On X-rays, we can also see humpback deformity when lunate is extended and distal pole of the scaphoid is flexed. MRI is basically to see the proximal pole non-union, and we have to order contrast enhanced MRI. But even with contrast enhanced MRI, there is failure to detect 23% of the patients. And according to this paper, many cases diagnosed as having avian may actually have had satisfactory vascularity of the proximal pole. So what do we do? So best tool to assess vascularity of the proximal pole of the scaphoid is to see intraoperative punctate bleeding by releasing the tourniquet. If there is no bleeding from the proximal fragment, it means that it is avascular. CT scan is mainly to see displacement of the fragment, humpback deformity, and comminution of the scaphoid. And whenever we treat these patients, our aim should be restoration of the length, restoration of the alignment by correcting carpal instability to achieve stability and compression, and ultimately to achieve union of the scaphoid. Approaches for waist and distal pole of the scaphoid non-union, we prefer volar approach between FCR and radial artery. Divide the radioscapulocapitate ligament and approach the scaphoid. In case of proximal pole non-unions, we have to go by dorsal approach between the EPL and EP first and third compartment. Then when we treat these patients after thorough curettage and debridement, after thorough curettage, we have to put bone graft. So available options are non-vascularized bone grafts, Matisse technique, modified Matisse method, and Fisk-Fernandez method. In Matisse method is basically using cancellous bone chips, and it is particularly useful in non-union without humpback deformity and carpal instability. In modified Matisse method, cancellous graft face each other and cortical graft lie on either sides because it also serves as a mechanical stabilizer of the non-union. In this patient of waist non-union of the scaphoid without deformity, it was approached from the volar side between FCR and radial artery. A S-shaped incision was made on the capsule, and now we can see the gap at the non-union site. It was curated till we can see good quality bone and cancellous bone. It was filled with cancellous bone graft and fixed with Herbert screw. At 4-month follow-up, the scaphoid got united nicely, and patient has got reasonably good range of movement at the wrist joint. So role of bone graft in case of scaphoid non-union is to promote union of the scaphoid, but it is not only that, it is also for restoring normal dimensions of the scaphoid and carpal alignment. See, in this case, when there is humpback deformity, proximal pole of the scaphoid is extended, distal pole is flexed, lunate is looking back. So we call this humpback deformity. So it is important to correct this deformity because persistent DC deformity disturbs normal kinematics of the wrist and decreases movement, and further it causes arthritic changes. So for such patients, we use Fisk-Fernandez method. This is a very good method. Here, we have to go by volar approach to correct the DC deformity, correct the humpback deformity, and put waist-shaped graft from the volar side. So this is the reduction maneuver in reduction maneuver. First, we have to flex the wrist. When we flex the wrist, it flexes the extended lunate. Then put radiolunate K-wire. It is a temporary K-wire. Then extend the wrist. When we extend the wrist, the distal pole of the scaphoid get extended. And on the volar side, there is gap is created on the volar side, and the non-union side got open up. So then we have to measure it and put waist-shaped bone graft. So here in this patient, with the arrow, we can see humpback deformity. And after opening up, this waist-shaped graft was put in there, and the deformity got corrected. So this is the this patient had non-union since 3 months. with a humpback deformity and displacement. So this is the immediate, in this method, we did Fitz-Fernandez method and put wedge-shaped bone graft. This is the immediate post-surgery X-ray. We can see bone graft at the non-union site, and same patient after 5 months, it got united nicely after removing K wires. And he had also achieved fairly good range of movement at the wrist joint. So another option for scaphoid non-union is vascularized bone graft. As said by Judith, dead bone added to dead bone will not produce live bone. So in case of proximal pole, avascular non-union of the proximal pole, vascularized bone graft is the treatment of choice. So available options are pedicle graft and free graft. Out of pedicle graft, Zeidenberg's graft is very famous. It is based on 1-2 intercompartmental supraretinacular artery, and other Matholin and Harley's graft is based on the pedicle from volar carpal artery. And free graft is from the medial femoral condyle. It is popularized by Professor Doyle. So you see this is the Zeidenberg's 1-2 ICSRA bone graft. Here, bone graft is taken from the dorsal side of radius based on the recurring branch of the radial artery. And so we'll see in this case, this patient had a non-union of the proximal pole since 3 months. Then it was approached from the dorsal side. We can nicely see the exposed scaphoid non-union site. Then this graft was harvested from the dorsal distal radius, and after releasing tourniquet, it was bleeding nicely. It was fit into that non-union site and fixed with the K wire because the size of the proximal fragment was very small. So this graft is a very good choice for AVN of the proximal pole, but it is not a good choice for waist non-union, as pedicle length will not reach there. And it is also not a good choice for waist non-union with humpback deformity, as it will require bigger size grafts. Medial femoral condyle free graft. This is a study by Professor Doyle, and this is basically a microvascular procedure where we put free graft in the scaphoid non-union. It can be used for avascular proximal pole and waist non-unions. It has sufficient amount of cortical and cancellous graft to create a wedge for correcting deformity in waist non-unions. It should be reserved for failed waist non-union cases. Volar radial artery based graft. Here, the graft is taken from the medial part of the radial epiphysis and vascularized by the radial branch of volar carpal arch. This Professor Matholin and Harley has an extensive study to find out the course of the artery and the dissection method of this graft. And they are using this graft for waist non-union also, because they say scaphoid heals early if we are using vascularized bone graft. So take-home message is properly done X-rays are required for diagnosis and decision making. And in case of scaphoid non-union of waist without instability, cancellous bone graft and stable fixation should be done. But whenever there is instability, we should use Fitz-Fernandez method, where we put wedge-shaped bone graft into the humpback deformity and correct it. But in case of avascular necrosis of the proximal pole, vascularized bone grafting should be preferred. I thank you very much.